This is the final lecture for the Difficult Airway Simulation Workshop. We'll be discussing extubation and endotracheal tube exchange. I want to start by saying that extubation is elective. Knowing who and when to extubate is just as important as knowing who and when to intubate. More complications arise during extubation and immediately afterwards than with intubation. When deciding if you should extubate someone, there are a couple of factors to look at. Was there difficulty during induction? Were they easy to ventilate and intubate? If you had trouble then, you're more than likely to have trouble again. What types of comorbidities are present? Are they a sick patient from the ICU who came intubated because they are in respiratory failure? Or are they young and healthy going through same-day surgery? Maybe they're obese and have sleep apnea or asthma or COPD. We also need to look at what type of surgery the patient had and how long it lasted. Extubating someone after a 2-hour ankle surgery is different than trying to extubate someone who has had a long general trauma surgery where their abdomen is being left open. There is research showing that a patient who has undergone an ACDF with more than 500 mL of blood loss, lasting over 3 hours, or having more than a 3-level corpectomy done, is at more risk for having difficulties with extubation. When surgery takes place in the face or neck, you need to take into consideration the amount of swelling they may have and if they are able to protect their own airway. In general, it's best to extubate while the patient is deeply anesthetized or awake. This decision depends on the patient and the type of surgery they're having. Practitioners often choose to perform deep extubations when they are worried about the patient coughing. Bucking on the tube can cause increased heart rate, blood pressure, central venous pressure, and intraocular pressure. It can lead to wound dehiscence and bleeding, and trigger bronchospasms and asthmatics. At the end of hernia surgeries and ear surgeries, I often consider deep extubation. If this is not appropriate for the patient, for reasons such as increased risk of aspiration, I consider other methods of emerging to prevent coughing, like waking up on remifentanil. When preparing to do an asleep extubation, you must ensure that the patient is in a deep plane of anesthesia. If there is any coughing or breath holding during suctioning, this indicates the patient is too light. Extubating when the patient is light could lead to laryngospasm. This is a forceful, involuntary spasm of the laryngeal musculature caused by sensatory stimulation of the superior laryngeal nerve. It is treated by removing the stimulus and applying positive pressure ventilation with 100% oxygen. If the spasm does not break with this, the patient be treated with succinylcholine. If not treated, the large negative intrathoracic pressure generated by a struggling patient can result in negative pressure pulmonary edema. Either awake or asleep, the patient must be reversed from muscle relaxants, oral suction, and on 100% oxygen. If there is concern that the patient will struggle after extubation, or that reintubation could be difficult, you should consider doing a leak test or extubating over an exchange catheter. I have done this and taken the patient to the ICU. They tolerated it well, and it was removed within 2 hours. No matter how confident you are that the patient will have a successful extubation, you should always be prepared for emergency reintubation. Exchanging endotracheal tubes is done for a multitude of reasons. The practitioner may want to go from a single lumen tube to a double lumen tube, or vice versa. It could be that there is a tear in the cuff. Exchanging a tube is at least a 2-person job. Before attempting an exchange, gather all necessary equipment, airway exchange catheters, laryngoscopes, or video-assisted laryngoscopes. There is a possibility that you might need a fiber optic scope or a video tower or even the difficult airway cart. Before starting the procedure, have a plan and make sure the plan is communicated to all in the room in case you need extra help. Ensure that you have a proper size airway exchange catheter and it fits easily into the tube. The patient should be on 100% oxygen. When placing the catheter, make sure that you do not hit the carina. You can tell where it is by the numbers. They should line up with those on the ET tube. I personally like to do this with a glide scope or CMAC so that I can watch the tube come out and a new one go in. Also, it allows your assistant to see what is going on, and it can be more helpful. If a new tube gets stuck at the vocal cord, turn it counterclockwise. Always have smaller tubes available in case there are problems getting the new tube in. Many catheters are set up with an adapter on the end of it so you can give supplemental oxygen via insufflation or jet ventilation. You have to be careful when doing this because the flow is too high, the oxygen can get in but not out. This could cause trauma to the lungs. That was the conclusion of all the lectures. I'll see everyone on Monday. Please bring your quizzes and any questions you have for me.